So Mr. Janos Balega is a consultant gynecological oncologist at the Pan Birmingham Gynecological Cancer Centre and an honorary senior lecturer at Birmingham University. He's an internationally renowned expert gynecological surgeon with particular expertise in fertility-sparing surgery for cervical cancer, advanced cytoreductive surgery, and pelvic exenteration.
Stop it, please. Thank you. Thank you so much indeed, Sumi, and the rest of the team to invite me again to the Delta. I was asked to talk about fibroids and sarcoma, and my talk is not going to be oncological. My talk is going to be a gynecology talk with my spectacles as a cancer surgeon on, and just kind of give you a little insight into this topic. If I share my
if you share your slides, yeah.
We all know that fibroids are one of the most common tumors in the female body. Nearly half of the ladies will have, premenopausal ladies will have fibroids of some size present. Most of them don't cause any symptoms. When they grow to a certain size, they can cause different symptoms depending on where they sit, whether it's pressure symptoms, whether it's causing abnormal bleeding, heavy bleedings, spottings, or if it's in the wrong spot, infertility. The treatment, very briefly, I'm not an expert of this, but we all know that there is surgical and non-surgical treatment available, hormonal treatment, uterine artery embolization, and after downgrading the largish fibroids, myomectomy. Obviously, the last desperate resort to manage these large fibroids is a hysterectomy, particularly on those ladies who completed their families. So when we talk about the hysterectomy and myomectomy, we also talk about laparoscopic approach. With the advent of laparoscopy, minimal invasive techniques, obviously boundaries have been pushed, and larger and more kind of complex tumors had been removed. One way to remove large solid tumors is piecemealing the tumor. It's called morcellation. There are special kind of techniques and devices for this morcellation technique, and that's basically what we are going to talk about today. What to be aware of and how to avoid some major trouble with piecemeal removal of any uterine tumors. We've already heard from a much more reliable source, the previous speaker talked to you about how difficult it is to to diagnose atypical fibroids, cancers, and we all know that when we remove a uterus, occasionally we find some incidental cancers. Next slide, please. Yes, thank you. And you can see these, so any sort of cancers you can find. Tubal cancer is one of those which you can't really see before, on preoperative imaging, and you can't really avoid this. And in fact, if you find one, the patient is lucky to have this removed in an early stage. Endometrial cancer really shouldn't happen, because usually patients with endometrial cancer, they do have symptoms and we usually diagnose them. Uterine sarcomas are possibly the most common malignancies incidentally found on hysterectomy specimens. Next slide, please. Yes, so sarcomas, they are rare. They are very strange tumors. They are arising from the connective tissues of the female genital tract, from vagina, cervix, rarely vulva. Cervix, most commonly they arise from the uterus, less commonly from the ovaries. It's always from the mesenchymal tissues, and they can arise from the endometrium, the stroma of the endometrium, or the myometrium, if you talk about uterine sarcomas. Risk factors, so we don't know why these cancers develop, but we have identified some risk factors. Previous radiation therapy, for example, for rectal cancer or for bone cancer, which includes the uterus, unfortunately have been showed to increase the risk of sarcoma development. Ladies of Afro-Caribbean origin will have higher risk of developing sarcomas. Obviously, postmenopausal women are at higher risk. Tamoxifen usage have been linked with endometrial cancer and at some degree to uterine sarcomas as well. And there is some equivocal connection between carrying the BRCA1 or 2 gene mutation and sarcoma presentation. Next one, please. So this is just a very quick diagram about how we categorize, how we classify the sarcomas. So leiomyosarcoma, obviously we heard about this type of cancer. The endometrial stromal sarcomas, they're quite frequent as well in our practice, mainly the low-grade ones, but we can find high-grade ones, and we've got undifferentiated types. They are quite aggressive. And there are rhabdomyosarcomas, adenosarcomas, a different type of sarcomas, depending on how they are mixed with other tissues, and we call them. Next one, please. So very quickly, just one tiny slide about endometrial stromal sarcoma. So it's a rare cancer. Mainly younger ladies are exposed to this cancer. A quarter of them will develop this cancer during their premenopausal age. And usually abnormal bleeding, if postmenopausal bleeding, largish uterus, these are the presenting symptoms. Because this arises from the endometrium, we can diagnose this before the operation, but it can also involve the myometrium. And we had cases when endometrial stromal sarcoma was diagnosed from myomectomy, with previous endometrial biopsy being negative. So next one, please. Good. So let's talk about the leiomyosarcoma, which is the more common and possibly the more vicious type of sarcoma we deal with. Again, a rare type of sarcomas. Again, quite young patients are exposed to this cancer. And unfortunately, this is generally speaking a very aggressive type of a cancer with poor prognosis, very high recurrence rate, even in spite of early stage cancers diagnosed on a hysterectomy. Very commonly, the patients develop liver or lung metastases after a hysterectomy, which found leiomyosarcoma. Unfortunately, chemotherapy, radiotherapy is completely useless upfront for an early cancer. It does not reduce the risk of recurrence as far as we are concerned. When they develop recurrence, it's very difficult to treat them, unfortunately. So again, these patients develop either heavy bleedings, but most commonly they are found on a hysterectomy, so or a myomectomy specimen. So as we heard on the previous lecture, very strange, funny changes, certainly looking like sarcomas, often turn out to be just degenerative fibroids, and vice versa, kind of indolent looking tumors on the MRIs can turn out to be leiomyosarcoma. So there isn't a very strong diagnostic way to diagnose these before an operation. Next one, please. Next slide, please. Thank you so much. So we talked about the morcellation, and now we understand that we've got a cancer which is confined to the uterus and which is very vicious. Not all of them recur, but a large proportion will recur in spite of an early confined stage to the uterus. But when we interrupt the uterus, unfortunately, we will spread leiomyosarcoma cells within the peritoneal cavity, and the two don't agree well. This is a death sentence, basically, to the patient. It's very difficult to make out, if you chop a uterus into pieces, it's very difficult to make out the pathology of it, how far it spread, whether the serosa was involved, and so on and so on. But to be honest, it's academic, because if it's morcellated and it's been in contact with the peritoneal cavity, unfortunately, the recurrence rate will be enormous. Survival will be shorter, and it's a difficult situation to salvage. The cancer, when you do a myomectomy, you don't know what's left behind, so you need to do a second operation to complete the surgical treatment. Next one, please. Yeah, so you may remember, like a good 10 years ago, the whole morcellation issue started in America. Obviously, if you've got, you know, a rare complication from a new technology, that can have a major detrimental impact on the technology in the US. So the American Association of Gynae Laparoscopists stated that the morcellator usage should be restricted. So they had very strict criteria. The FDA had done quite a thorough kind of assessment about the incidence of incidental sarcomas found, and they did 2 assessments. As you can see, 1 in 300, 1 in 300 and 1 in 360 by 2 different methods was the incidental sarcoma risk. You can see the leiomyosarcoma risk, but it doesn't really matter which sarcoma. It happens in 1 in 300, basically. That's all age group. So in 2017, they reviewed their statement and they maintained they did not recommend morcellator usage for certain patient groups. Next one, please. So yeah, and this is just a kind of outline of what they talked about. So of course, if you suspect that it does look like a dodgy looking fibroid on MRIs, you don't start doing myomectomy and all of those operations, because you can harm the patient. If the uterus is removable in one piece, then try to do that either via a mini laparotomy or via the vagina, and to morcellate. Don't chop it into pieces. Even if it's benign, apparently morcellation will increase the risk of parasitic leiomyomatosis risk. So it is basically it can be detrimental for patients with benign disease. Possibly we all seen these benign leiomyomatoses. They are very vicious, and there isn't very good medication for it, and they are very difficult to remove. So the BSGE, the British Society of Gynae Endoscopists, also had a proclamation which was possibly a bit less harsh, but still restrictive, and warned doctors about the risks of morcellating the fibroids. Can you please move on? Thank you. So how can we avoid getting into trouble? I think it's not rocket science. I think we just have to use our common sense. So patients who keep bleeding, and you take a biopsy negative from the endometrium, take another biopsy negative, the patient has got some fibroids, she's 56 and she keeps bleeding, you have to regard this as cancer until it's otherwise proven. So my colleague used to call this beware of the weeping womb. So basically, a uterus which keeps bleeding should be highly suspicious of malignancy. We used to say that, you know, if a fibroid rapidly grew, that was a very bad sign. In premenopausal women, it may not be. So this is an equivocal statement. But obviously, on postmenopausal women, there should not be growing fibroids. There should not be estrogen, which feeds fibroids. So if you've got a 65-year-old lady with a large fibroid, this should not be there. It should have resolved already. So obviously, MRI findings, we talked about those, very, very difficult to diagnose leiomyosarcoma upfront. And we are aware already the kind of red flags, postmenopausal age, post radiotherapy, patient has got bleeding uterus. So these, you have to put these together. Next slide, please. So there is apparently RCOG consent guidance on this. So I advise you to visit the website, and this is very similar what I explained to you. They also talk about that if you've got a hormone-resistant kind of fibroid, it doesn't really decrease in size after administering GnRH agonists. Then you have to think about why is it just simply non-responsive, or is it a malignancy? So they have kind of concluded the same what we discussed before about suspicious signs for sarcomas. Next one, please. Yes, so that's a very good a paper which stratified the risk to age, and you can see that obviously the older a patient with a fibroid, the higher the risk to find some incidental sarcomas. But even for the 55-year-old category, it's 1 in 200. So it's really not a very common scenario. And obviously, for patients above 50, I don't think anybody would like to consider uterine artery embolization or myomectomy. Next one, please. Yes, so I don't want to waste your time on this. Our previous speaker talked about this. There are some suspicious features on MRI, but MRI scan is not a diagnostic tool for Lyme sarcoma. You really have to have something very bad happening in the uterus when you suspect a sarcoma. But there are no definitive diagnostic criteria on MRI scan. You can suspect, but you can't diagnose it. And yeah, I mean, as said, I've been there before. It looked sarcoma on the scan. While doing the hysterectomy was a terrible, difficult operation. I was convinced the woman had a sarcoma, and luckily it came out as a degenerative, not even an atypical. It's a simple degenerative fibroid. So it's very, very difficult to diagnose them beforehand. Next one, please. Yes, so that's a pretty good paper about nearly 5,000 patients who underwent operation for fibroids. Next one, please. So they stratified patients, underwent laparoscopy, underwent laparoscopic morcellation. So 1,800 patients received morcellation, and altogether 26 patients were diagnosed in this whole group of nearly 5,000 patients. 26 of them were diagnosed with Lyme sarcoma. But then if you read this paper, you have to be just careful, because previously, but before the operation, there were suspicions. 6 patients had already diagnosis from biopsy. So altogether, if you check it, 1 in nearly 200 patients had Lyme sarcoma in the fibroid. But if you kind of use your logic and your common sense, you only found one unintended morcellation. They found one unintended morcellation resulting Lyme sarcoma diagnosis in these 5,000 patients. So I do believe that you just have to be cautious with these cases. So finally, I'd like to just take you through how to kind of approach a patient with a large fibroid. I've seen the general gynecologist struggling with these operations. They can be very difficult operations with no space between the tumor and the sidewall. Cervical fibroids are especially difficult, and you need to do a kind of time radical hysterectomy time of operation to lateralize the ureters. If the tumor goes gets up to the rib cage, obviously it's a very, very difficult operation due to access. So I do believe that these operations should not be just done by any gynecologist. It should be done by those with experience in open surgery. And I said surgeons because I would encourage you to kind of use the body operating. So 2 surgeons, these are rare operations. So 2 surgeons, more confidence, less risks, and more learning potential. Please do apply a patient into a Lloyd Davis position. So the legs should be up. You should have access to the cervix. Before the laparotomy, you should examine the patient and feel what's happening. Is this a tumor which descends down and occupies the cervix? You do need to call a gynae oncologist or a urology surgeon or so. And this can also help you when you open the vagina during the laparotomy. An internal examination can define where the vaginal vault is. It's not always obvious. Needless to say, having said that, I've seen, unfortunately, examples who did not follow these principles. Midline laparotomy, there's no question. For a large fibroid or a fibroid uterus suspicious for sarcoma, it's a midline laparotomy. There's no question. And you have to basically find the ureters early, make sure that they are lateralized, and then you can obviously perform the resection. Please do avoid performing a subtotal hysterectomy. Subtotal hysterectomy is a mistake for these patients. You may cut through the sarcoma and you do the spilling of the sarcoma cells to the peritoneal cavity. Also, you can leave some disease in the cervix. I've seen people, even just for benign fibroids, cutting too high, leaving some endometrial tissue on the top of the cervical stump and giving the patient hormone replacement therapy and endometrial cancer developing. So one has to be very careful with the subtotal hysterectomy application in this situation. And I think my final slide is just to conclude. So if the patient has large fibroid and the bleeding is completely abnormal and the patient is near 50 or perimenopausal age, be very cautious how to kind of follow this up, whether you offer or not a surgery and what's the surgery you offer. Do not think about uterine arterial embolization, obviously. So MRI, when you've got a large fibroid, I would definitely perform an MRI scan that can help you planning your surgery, even if it's a benign case. If there are any suspicious features on the MRI, please do bring this to your gynae MDT, the cancer MDT. There are people there who've got more experience with these, radiologists and surgeons. And we talked about, avoiding uterine artery embolization and myomectomy, or chopping the uterus into pieces beyond age of 40, near 50. One has to be careful. And yes, we talked about the experienced surgeons and the team approach and the adequate exposure and an incision about during these operations. So I think that was possibly all. I tried to bring you some it's a general gynecology topic, and as said, with an aspect of oncology, how to avoid kind of oncological complications. Just wondering if you got any questions.
Thank you, Jonas. That was a good run through of fibroids. I think one of the issues people have raised before is that that not knowing when to potentially treat them seriously. I think some important principles, as you rightly said, when you've got red flag symptoms, when you've got somebody's perimenopausal, you see people treating them just like fibroids. You've got pain persistently there. And so we have to manage them, as you say. You can't just sit on them and say manage conservatively a lot of the time, or doing a TCRF. I mean, we have some colleagues who try and do TCRFs on these patients at the age of 45 plus, which I find bizarre. Any questions? Yeah. Ismail, you asked for this talk a few years ago, which is why we've asked Janos to present. What's your question? Do you want to turn your camera on?
Yeah.
Turn your camera on, please, so
yeah,
we can.
Yeah, it is very excellent, actually, talk. Just a question: when we counsel patients, because it's a very common problem, and especially in the general gynae outpatient clinic, when you counsel patients regarding the risk of cancer in a fibroid, what figure actually you tell them? Because it's mentioned 1 in 350, 1 in 4,000, what actually figure you tell your patient?
Yeah. I myself would say that 1 in 2, 1 in 300. That's possibly you don't make a major mistake. The problem with this is that you may not even do 100 hysterectomies in your whole career, okay, nowadays. So you don't understand what this guy is talking about. The problem comes is that if that one case comes, I think people will look at you with scrutiny, but you've done everything in your power to avoid this situation. And obviously, as Sumi said, that, and we had this before, 49-year-old lady with a big uterus, perimenopausal, and she was referred to the radiologist for consultation of uterine artery embolization. And I feel like, for the God's sake, guys, let's be realistic here. What do you want to achieve here with a large fibroid? Even in a young one, it may not even work because it's so large, multiple fibroids, and this is a perimenopausal woman. So I think you just have to use the principles of the warning size and the age, and mention, in one short sentence in your consent form that, incidental sarcoma, 1 in 300, something like that.
Thank you.
Any other questions? Susie, you're muted.
Yeah, I'm just checking the chat box.
Yeah, there is a good one here. We found in predominantly Afro-Caribbean population in East London, a 1 in 100 sarcoma rate, which is kind of consistent with what I explained to you, that raises the risks, and obviously we can't. So there is our population is not homogeneous. We've got groups where there is a dense population of Afro-Caribbean ladies or Asian ladies or so. So we have to apply the numbers. I'm amazed. 1 in 100 is not that, negligible, isn't it? I don't know who sent this.
Yep.
Sean, yes.
Okay. Susie, do you have a question, or you just got a hand raised for?
Oh, do I have it raised? Sorry.
Yeah, sorry.
I was going to ask though, with it being such an aggressive cancer, if it was picked up incidentally on myomectomy in a young patient who was nulliparous, is there any rule or any criteria for patients that you might consider fertility preserving options versus sort of completion surgery by way of hysterectomy?
Okay. So it's a very difficult one. I think we have to be, again, very realistic here, how far we would like to push the envelope. Just to tell you, my lady, 32, she had a myomectomy, bound or typical fibroid, had the myomectomy, was removed, bing, it was low-grade endometrial stromal sarcoma. We had another MRI scan. There's nothing on the MRI scan, no discrete lesions, nothing. We were hesitating a lot what to do, but we came to the conclusion in the SMDT that hysterectomy would be the standard treatment. We keep the ovaries because what if there is no residual tumor? Maybe we did the I did the hysterectomy, I remember, and I found a little tiny spot on the bladder, like a white little spot, because I've got very Hawkeye. I'm oncologist, so I just removed that. We did a hysterectomy, and it was full of endometrial stromal sarcoma in spite of a negative MRI scan. It was completely occupying the uterus, and the little tiny biopsy was a endometrial stromal sarcoma, very likely the spread. So we went back third time to remove her ovaries because obviously low-grade endometrial stromal sarcoma is an estrogen-driven disease. That's the one rare kind of complete contraindication for hormone replacement therapy, and we removed the ovaries as well.
Thank you.
So,
Claire, one last question. Claire, do you want to ask your question if you want to turn your camera on?
Sumi, sorry, my camera's not working. It's just
All right.
a quick question. So in Kettering, I've had a couple of cases where we've had to do an emergency hysterectomy on, for literal heavy bleeding.
yes.
And one of them was fine, the uterus came out whole, but the other one, the uterus was so big. And I had an experienced colleague with me, and we literally had to decompress it by coring out the middle because there was no way we could access the pelvic sidewall. And of course, regrettably, the histology came back as a sarcoma. Have you got any tips to try and avoid doing that when the uterus is so big?
My wisdom here is that there's always a better surgeon. Okay, when you feel that you are the best, there is always a better one. So it's you had two of you experienced surgeons. The only thing is, what I know is that the problem is that Kettering, I don't know where the next kind of cancer center is, but if this operation happens in our local hospital, they may not be able to call me in. So the gynae cancer surgeons, we do have tricks with the sidewall involvement, but as you said, sometimes we are stuffed as well. If there's zero space there, sometimes you do some desperate things and you say that let's save the patient's life. I don't have a miraculous solution here or one trick to solve the problem, to be honest.